Hello, everybody. Can you hear us okay in the back there? Okay. So, thank you for coming. We're going to be talking about the navigating unique challenges in pediatric emergency care from a rural standpoint. My name is Kat Bryant. I'm from East Carolina University, which is in Greenville, North Carolina. With me, I have Sunny Kanth and Juliana Jaramillo, also ECU. Then we have Kristen McGill, who is at Carolina Medical Center in Charlotte, North Carolina. And unfortunately, our fifth presenter, the weather made her flight get canceled. And so Liz Olson, who is at Augusta, Georgia at Medical College of Georgia, could not be here, but she helped with presenting this today. We have no disclosures or any conflicts of interest. Today, what we're going to be talking about is recognizing the barriers of care that is disproportionately to rural populations, looking at special populations within the rural communities and how they're impacted, pre-hospital and hospital issues specific to this population, and then also finally looking at next steps and where we can improve that care. So just a little bit of background in barriers of care specific to rural communities. About 1/5 of the U.S. population is in rural communities. Those communities also face significant healthcare challenges. There's less access to healthcare providers availability, and within that, there's also a small proportion of that population has financial resources or health insurance. That then contributes to overall reduced access to healthcare compared to urban and suburban areas. Travel distance is a major barrier to healthcare. Rural Americans, on average, live 17 minutes away from the nearest hospital. That's nearly double the average distance for urban and suburban. Within one in four of those rural population, they actually live up to 34 minutes away from the nearest hospital, which can be very critical in an emergency setting. Beyond distance, provider availability is another issue, particularly specialists. Rural hospitals are more likely to be government run, and that's what this shows here, with less resources and less specialists, and this access is worsening. Between 2013 and 2020, 4% of hospitals closed. That led to an average distance for inpatient care jumping from 3 to 24 miles, and for specialty care jumping from 6 to 45 miles. Just talk about special populations. So within rural communities, certain populations are affected more. In particular, in 2018, over half of rural counties lacked obstetric care. That then leads to increased maternal and infant health risks, such as preterm births and longer distances for that care. And unfortunately, that is worsening, that they are predicting that by 2030, 50% of OB demand will not be met in rural areas. The other populations, healthcare outcomes are disproportionately affected to low income and minority population, particularly Black and Native American populations. And this is compounded barriers due to both racial disparity and economic hardship. And you can see here with this, pointer's the first one, right? There you go. So this heat map shows the darker the blue, the better the health of the community, where the darker the purple is the worse health of the community. And you could see where the purple areas here on this map match up with the different clusters of minority groups on this map.
All right, so now that Dr. Bryant has provided that background, I'd like to bring you guys to our emergency department. So I trained in Brooklyn in New York City, and I thought, I knew what to expect moving to a different part of the country, and then I came down to North Carolina, where I definitely saw things that I had not considered when I first made it here. So one of my first shifts actually in the pediatric emergency department, they announced that we were getting a kid that had fallen into a trash pit. I had no idea what that meant. In terms of apparently in certain rural and suburban areas, they don't have like trash pickup and whatnot. And so they actually burn the trash. And so this is a fairly not kind of common occurrence of something that you can have coming in. The other thing that I ended up seeing a lot of is kids coming in with amputations or severe lacerations after falling off a riding mower or something of the sort. And I, again, had not exactly encountered that. So also because you have more land, kids are coming in with all sorts of injuries from like ATV accidents. I even saw a toddler that was on like an ATV-like machine, whatever. The other thing that vehicle, that would be the word. So the other thing that you will see in our area is all sorts of insects and snake bites and things like that. I will say I was on shift and they brought in a toddler that was at a daycare that got bit by a copperhead. So, don't forget that since we're in more rural areas, we have lots of farms, which means lots of farming equipment nightmares, and you have various accidents related to the equipment. There's been cases where people can fall into the silos and get trapped and suffocate. Fun fact, North Carolina is the second largest producer of tobacco farms. So we see cases where kids are playing in the field and they end up presenting with a nicotine toxicity. The other aspect is we, because of the large number of farms and everything like that, you have migrant farm workers. And we are actually, North Carolina is the sixth in the country in the number of migrant farm workers. And so that presents a unique set of challenges with the occupational hazards, language barriers, delays in presentation, which can mean some increased severity. I will say, migrant farm workers are exempt from your labor regulations, which does include protections for their children. So North Carolina child labor law permits children as young as 12 years old to, and in some cases 10, work in the fields. And there's even cases where they commented on someone that was 6 years old working in the fields. That being said, child laborers are going to be at even greater risk of injury and death. There was one source that even reported that 1 in every 5 work-related deaths were children from working in the fields.
So pre-hospital care to patients who are in rural settings pose a lot of challenges also to the pre-hospital clinicians, the EMS clinicians who are caring for these populations, but also for the EMS agencies who care for these patient populations as well. So there are things called ambulance deserts that exist in the United States. And these are locations and regions that do not have an ambulance that's immediately available to them within 25 minutes. And this is a sample map of Alabama, but there are maps like these of every state in the United States. And this is something that's a particular area of research for University of Southern Maine. This was presented at one of their research conferences. So this is also something that was presented by HRSA at the 2022 at one of the 2022 conferences that HRSA presented to the Department of Health and Human Services. This basically demonstrates that the percentage of critical calls and also emergent calls, but specifically critical calls to rural and frontier EMS agencies are double what urban agencies. Now, this is a percentage. It's not total volume of calls. But as you can see, the percentage of critical calls far surpass those that urban and suburban settings get. And then the same is to be said for emergent calls as well. They have a higher percentage of emergent calls that they will get in the pre-hospital settings, in the rural and frontier settings. And then in addition, this was also presented at the HRSA presentation in 2022, and this is also available online, but the funding that EMS agencies get is based on the volume of calls that they get. So the number of phone calls that they get to treat pre-hospital patients is far lower in the rural and frontier settings. So the refund dollars that they get back to be able to fund their agencies are much lower than we get in the urban settings, okay? Which can pose a lot of difficulties, especially since if you consider that Medicaid dollars actually treat ambulance transports as transports. They actually don't treat these as trained clinicians who are providing medical services for these patients. And so when we're talking about issues of non-transport, that becomes a big issue. So not only are some of these agencies going a long way to treat some of their patients, they're also providing a lot of critical care for extremely sick patients. But then if the patient or the family ultimately decides that they don't want to actually be transported to a facility, that entire service may not be reimbursed if we're working off of Medicaid dollars. So something very important to consider when we're talking about how these pre-hospital agencies are able to continue to function and be able to service the patients who are there for. So I actually had the opportunity to speak with some EMS clinicians who've worked both in urban and in rural settings. And these are some of the insights that they had to consider that they have either dealt with or that they may have been worried about when they were working in rural settings. So first thing to consider is that the equipment that you have is limited when you're working on an ambulance, okay? There's only limited space, and you may only have one item of each size of something, and we're talking about tiny pediatric patients, that can make a big difference. So think about it. If you consider that if that piece of equipment that you have, that's the specific size that you need for a patient, if that piece of equipment malfunctions, or if it's been used at a previous call and you haven't been able to restock it, that can pose a lot of big issues that can really impact the care that these patients will get. Also, think about it. If you have a 45-minute transport time and oxygen for a patient runs out because you have a limited oxygen tank on these ambulances, and that runs out in the middle of your transport call, that can also pose big problems. Something else to consider is that ambulances are machines as well. Ambulances are vehicles. They may break down. They may get a flat tire. And it may be at a critical time when it's going to be difficult for these rural ambulance companies to be able to come out. And if it happens in the middle of a transport call, you may be in a very difficult situation. So the other thing to consider is that the EMS personnel, when they first go through training, they may have limited access to be trained for pediatric patients, okay? And then also as they get further along, if they don't have a lot of contact time with pediatric patients, their confidence in their ability to be able to provide care for these patients goes significantly down. And again, like I mentioned before, they're transporting really sick kids and they're transporting them a long way. So this plays into something called the rural-urban paradox, where the more highly trained and more highly skilled EMS clinicians tend to be in the more urban areas with shorter transport times, whereas their skills could actually be very useful in the rural settings where the transport times are much longer and there tend to be a higher percentage of sick patients. Something else to consider is that the transport time may be 45 to 60 minutes, and that doesn't actually include the time to be able to get to the patient to be able to do the assessment. So that's a long time to be caring for a pediatric patient, especially if you're a clinician who doesn't take care of a lot of pediatric patients, and your confidence level in taking care of this really sick kid is going to be for a long, long time. And also keep in mind that some of these counties that we're talking about can be over 300 square miles. Something else to consider is that ambulances and pre-hospital vehicles need to navigate rural roads and rural transport areas. And if you consider that some of these roads can't be very well maintained because the county resources for infrastructure may not be very high. So trying to get to the patients can prove to be very, very difficult. Some rural access is only down dirt roads, or even if you consider after a hurricane or after a tornado, or even after just a severe storm, roads may be flooded, they may be washed out, or bridges to island communities may not even be accessible. So this can delay care to patients for days or even weeks. And then communications, when you're talking about being in a rural setting, the cell phone coverage or even just radio coverage, if you're trying to use walkie-talkies, may not be very good at all. And so trying to get in touch with somebody from medical command to be able to get medical direction or to be able to call for assistance if something happens with your rig or you run out of a piece of equipment. Or even talking with the patients and families, the health literacy in the rural population tends to be lower on average than the health literacy in urban populations. There may be some populations who don't speak English as a primary language, or they may even not have full legal status in the United States, and so they actually don't call for medical help until the situation is extremely dire and their child is very, very sick. All things to consider and all things that are considerations for our pre-hospital clinicians. But they did want me to share that there are some very positive things to bring up in the pre-hospital setting as well. So first thing is that there are a lot of rural hospitals that do admit pediatric patients, and they may even have PICU and NICU care. Oops, sorry. They also don't necessarily always have to go to the big city to get things like IV fluids, IV antibiotics, or even to get low-level respiratory support. The pre-hospital clinicians tend to be very proud in the rural and small communities. They tend to be very proud of the resourcefulness that they have as well, and their ability to manage things in resource-limited settings and austere settings. Also, they tend to be part of the rural communities that they are servicing as well, and so they tend to be very, very tight-knit, and they're proud of that as well. And they tend to know the people who they're taking care of. And then lastly, the Pediatric Pre-Hospital Readiness Project has also put out guidelines for EMS agencies to make it easier to be prepared to take care of pediatric patients and to do recertification training and to do additional CME training. So those are things that are positive on the horizon.
So as an adjunct to the out of hospital care, we have our county health departments. Did not click yet. They play a vital role in the U.S. healthcare system, and they provide essential early periodic screening, diagnosis, and treatment. Examples of that: prenatal care, perinatal care, pediatric care, immunizations, and mental health. They also play an important role in caring for the undocumented, and for obvious reasons, data is limited on that, but we do know, at least from our local health departments, that that does exist. When county health departments are the only medical access in a region, and compared to other health departments, these ones that are the sole healthcare providers provide 4 times more the ESP, DT, and 6 times more of the prenatal care. Latest data from 2016, though old, shows that there's a significant reliance on these health departments. So over 60% in the urban environments and over 70% in rural environments, showing the essential safety net that they provide in our healthcare system. With regards to their funding, health departments are a combination of service revenue and federal allocations. This leads to a difficult funding model for rural communities because on average, income is going to be lower and the ability to pay is going to be lower. And then the volume when compared to urban settings is lower too. So again, the resourcefulness of county health departments are very critical in these communities. Moving on to hospital care. Even with county level supports in place, typical rural areas struggle with resources that other areas can take for granted. Although many individuals, I'm sure here at this conference, do not live in a rural community, they may not have access to 24/7 retail pharmacies. For example, in Augusta, Georgia, home of the state's only public medical school and a metro area with over 500,000 people, they do not have a 24/7 pharmacy in that region. So in practice, what does this lead to? Well, you can treat your patient for an asthma exacerbation, and 2 hours after they get home, the neb's worn off and they don't have an MDI, they bounce back to your ER. Or they get to the pharmacy only to realize that the antibiotic solution is not on their formulary. Alternatively, if you're going to wait for your pharmacy to dispense a medication, this is going to lead to some delays in terms of disposition, or your inpatient pharmacy may not have said MDI inhalers or epinephrine autoinjectors. So as much as we try to anticipate medication needs before patients are discharged, overall, it's very hard to discharge a patient and then put them in the waiting room to wait before they leave. So this is all a cascading effect on decreasing throughput through the emergency department. Now, another unique issue is technology-dependent children losing electricity due to natural disasters. And we're not talking about Fortnite and Roblox and PS5s here. These are children who rely on home vents and feeding pumps. So these families often will preemptively make their way to children's hospitals that are geographically much further where they would usually go to. Sometimes as an intermediary, they may actually go to the closest community hospital, but then require that transfer to the tertiary or quaternary centers, further putting strain on the limited resources that our community and rural hospitals have. Another issue that can occur is with natural disasters and losing electricity. So just like we triage in the emergency department, the utility companies would have to do the same to triage who gets priority on getting their electricity back. And usually it's the highest yield, denser population centers Therefore, meaning that living in a rural community, you can have absence of electricity for a prolonged period of time. One strategy that can be mitigated is having our patients' primary care teams generate a letter to the utility companies in advance, informing them that there is a patient or patients with technology-dependent care at said addresses, and hopefully they can prioritize that. A study out of Columbia University looked at the effectiveness of an 8-point checklist to help families prepare for electricity outages, and they found it very effective and helpful for these families. However, resources is an important thing, particularly battery backups or generators. These are not cheap things to house for all of our patients. So, we've covered a lot of ground today, and we may not have the power to enact immediate change. However, we would like to provide 2 strategies and solutions to empower you to bring back to your emergency departments. We know that many rural residents may turn to telehealth services when that care is not available locally. Telehealth can be used to address limited provider availability. However, a 2019 study showed that up to 17% of rural communities lack broadband internet when compared to urban settings, being as low as 1%. Nevertheless, telehealth can be leveraged to help rural communities access PEM consultants without having to transfer them across the state. For example, the Medical College of Georgia implemented a teleconsult service servicing 15 other hospitals in their region using high-fidelity two-way audiovisual carts for their virtual consultations. These carts were expensive, but fortunately they had a grant from the main hospital rather than putting that stressor on the community hospitals to provide that service. From a PEM perspective, they're seeing a few or to several consults per month, but to use this technology, they're discussing other services to also use the telehealth carts. Lastly, I encourage you to work with your department leadership to evaluate your pharmacy access. On one hand, we can push for a 24/7 discharge pharmacy based out of the hospital, and when this does occur in hospital systems, this increases the fill rate of over 88% on critical medications that we dispense from the emergency department versus 33% from prescriptions that we send to pharmacies. One thing to keep in mind, this is resource intensive and requires a lot more barriers to get implemented. Another less resource intensive and possibly quicker strategy is setting up ED dispensing programs for specific medicines like we did at ECU Health. In general, we would have patients with asthma exacerbations and we use an albuterol MDI and it's working fine and we leave it on the counter just to be thrown away with a wink and a nod and somehow it ends up in someone's pocket or purse, right? And we're not condoning this. This is not the appropriate way for medications to be dispensed. However, at ECU, we found a way through our state prescribing criteria to label these MDIs from our main pharmacy so our patients don't have to go to a CVS or Walgreens to have this filled. Another strategy that you would need to take is maybe look at your most common or high yield medications. Of course, cost prohibiting. So we can think about antibiotics. So in the pediatric population, amoxicillin is going to be your number 1, 2, and 3 most of the time. We can consider insulin as well too. Now cost may be questionable, but this is life-saving, life-dependent medication, and epinephrine auto-injectors. One thing to keep in mind in terms of the logistics is looking at your state's regulations and seeing where locally in your emergency department you may have space to accommodate for this. So, in summary, today we discussed the barriers to care that disproportionately affect our rural populations, including geography and access. We identified special populations, including minorities, perinatal patients, farming communities, and migrant workers in the rural setting. We reviewed pre-hospital care access issues that uniquely affect our rural populations, and discussed the importance of county health departments and the increased importance for rural communities, and finished up with strategies such as telehealth and ED pharmacy dispensing medications to improve our rural care. Our references and acknowledgments are here, and you can scan this QR code to get a link to a Google Drive with our articles and the links that we use for our presentation. And we thank you for your time.